So quickly through the study design, we're relying on 3 previous and new investigational drug applications that were done with AAV1 that we generated at our center for safety data, as well as studies within the Pompe animal. We've done a mouse biodistribution study, as well as rabbit evaluations, which is kind of the smallest medium size that we can do that's within the range of the subjects. And we've done some primate studies to look at longevity of expression. And you can see here, this is what a rabbit diaphragm looks like. This is from a 2-kilogram animal, so that's about 5 times smaller than the youngest subject, and we can still get very high expression by injecting the AAV in 3 sites in the diaphragm. Really the only thing that's different about this from the other studies that have been done through intramuscular injection where the muscle is accessible by the skin is this is done through a pencil-sized incision to look in at the diaphragm and do the injection, which is very similar to the technique we used in a study of an inherited eye disease, which has been published about a month ago now, called Leber's congenital amaurosis. And this access to the retina in that case is also through surgery. So the surgical access to the site of delivery is not so unusual, especially if it's only once. And in the macaque, these are young monkeys. The vector was actually delivered into the whole chest cavity, not specifically to the diaphragm, because they're actually about 200 grams when this is done. And you can see out to a year in these animals that we get very high expression both in the diaphragm and in the intercostal musculature by giving it in the whole chest cavity. And this may be a strategy that's used in the future for diaphragm or thoracic delivery. So the study is at a single site. It's an open label study, meaning everyone knows they're getting the active study agent. It's a single dose in 3 injection sites on each half of the diaphragm. Very hard to study respiratory function if only one diaphragm is working better than the other. So we're going to actually propose to treat both sides. There's a dose escalation between these 2 groups. So it's really a very small study, only testing this effect on 6 subjects in 2 dosing cohorts shown here. The material is made, as we've done for every other study, under full CGMP conditions like we would for any biopharmaceutical. This is an investment we made in a facility at Florida now 6 years ago, supported 4 other studies from this facility, and the manufacturing for this is underway, and we expect by November to have the material completed, to be tested for all of the release criteria that are shown here, and that takes about a month. Once that release testing is available, we'll send our entire study information, including the IRB approvals, to the FDA to be reconsidered now that we've had our initial meeting with them. And this is the timeline. Patients are assessed for their baseline assessments 2 weeks before the surgical date. They get the vector injected on day 0, and really as a safety study, we're really looking at biodistribution into the blood, as we've done for the other studies, the immune response to the vector itself or to the gene, human GAA, and then respiratory function studies done at 3 time points and a year of safety assessments in the patients. And the inclusion criteria for this will be no males or females, at least 3 years of myozyme therapy where there's some evidence that this given patient has had progressive respiratory dysfunction leading to invasive ventilation. So, and we think that maybe in the less than 12-year-old, we still have a chance of improving some aspects of that if there are patients in that age category. They obviously have to have Pompe's disease. They have to be on assisted ventilation and able to participate in the long-term follow-up. We don't want anyone with a recent infection. Bleeding tendencies would be a problem in terms of doing the delivery because it is a surgical procedure. Therefore, these other exclusion criteria related to breathing or concomitant viral infections. So the injection site will be assessed both at baseline and intraoperatively. There are Blood chemistry is done, pulmonary function tests and safety monitoring of ECG. We'll look at the chest tomography to see what the diaphragm structure is like. The immunologic assessments are shown here. Biodistribution is just through blood drawing, and a long-term follow-up, as is all patients who enter into gene transfer protocols. And the pulmonary function testing is using spirometry, which is just measuring the quiet breathing. There are some measures that can be done in younger children that don't require cooperation, looking particularly at this pressure generated during the first 100 milliseconds of inspiration. This is kind of a surrogate for diaphragm strength. In adults, one can do forced maneuvers, but we're not expecting this patient population to really want to cooperate with that. So we're actually going to use a new technique, somewhat like the whole body plethysmography, something called resistive plethysmography. And the patients wear a garment that's designed just for them. It measures respiratory function over days or weeks, if you choose, to get a little more information than we would at a single pulmonary function test. We'll monitor their ventilation use and their immune response to either GAA or the AAV1 itself. And there's some rules always for stopping. We have to monitor carefully for adverse events or serious adverse events, and that will determine whether we can dose the next patient. Studies being supervised by a Data Safety Monitoring Board. So just to summarize, we know a lot about Pompe's disease now through the really successful studies that have been done with Myozyme thus far. We still see some needs of the patient population, and I think in these young patients I found very challenging to manage these respiratory problems. Many of the other things can be mitigated through assistive devices, but a ventilator is a difficult assistive device to be tied to when you're a young child. So we think there's a need to address this in this patient population. It's really, we think this common mechanism makes sense in other LSDs. There's clearly a neuropathologic component, and although we think that there's really not an effect in the brain, the cognitive problems are not seen predominantly in these patients, and so, but this new feature really is uncovered in the young patient population because they've survived. And as was mentioned earlier, the natural history is changing, and so we need to be responsive to that. And I think the pivotal studies of ERT have led us to a new era of how we can use concomitant therapies, additive approaches, things that work by different mechanisms to try to get an overall improved result in the end. And it's been mentioned by many, this is really a multidisciplinary effort. And I want to thank certainly everyone who collaborated on the ERT studies and the team at Genzyme who helped put this together. We continue our collaborations with Nina Graben and Paul Plotz and group at Children's who's helped us study the cardiac outcomes in the patients, and the group in my lab, some of whom you've met already. So I'll